I think this is the last panel of the day, titled Psychedelics as Medicine. My name is Kenneth Tupper. I'm the Director of Policy at the British Columbia Centre of Substance Use, and I'd like to thank the panelists who are joining us here. And I'm going to just read a very brief bios, and then I'm going to give a bit of an introduction, and each of them is going to speak for about 10 or 12 minutes, and then we'll try to leave time for some question and answers at the end. So first off, Zac Walsh is a researcher and clinician at UBC Okanagan, based in Kelowna. Joanna Simundic, you want to wave, Joanna, is a psychotherapist and clinical investigator and therapist with the MAPS clinical program for MDMA-assisted psychotherapy, and she works in New Westminster in Vancouver. Nitasha Puri is a clinical assistant professor at the UBC Faculty of Medicine and a medical doctor. She is based here in Vancouver, British Columbia. And Gabor Maté is a retired physician, author, and speaker. He leads plant retreats, including next month in Puri, and he works in Vancouver, BC. So first I want to see a clicker working here. Tech guy is the... There we go. So just to acknowledge conflicts of interest, no commercial or financial conflicts, but the BCCSU is receiving financial support from MAPS, the Multidisciplinary Association for Psychedelic Studies, which is a US-based nonprofit education and research organization, to conduct one of the sites of the phase 3 clinical trials for MDMA and PTSD, which Joanna's involved with and we'll speak more about, and Natasha's the PI of. Also want to respectfully acknowledge that we're gathered here on the traditional unceded territory of Coast Salish peoples, the Squamish, Musqueam, and Tsleil-Waututh. And I think this is even more crucially important because we're speaking about traditional Indigenous knowledge and healing practices. We're going to speak about the sort of modern incarnation, but the variety of plant uses goes back thousands of years, with plants that have visionary properties that have been understood as important epistemological and cosmological ways of engaging with our universe, and have been respected or revered even for their healing properties, their educational properties. And so we're going to speak about the sort of modern incarnation of how this has evolved. But certainly it's a long-standing sort of human practice engaging in the altered states of consciousness, in shamanic-type rituals or healing ceremonies. This is a visual illustration by Alex Gray of what's called the stoned ape hypothesis around the potential role that psychoactive substances would have played in early hominid evolution. So to fast forward, the sort of modern psychedelic movement really got going in the 1950s after LSD had been discovered, and was part of what was sort of the modern psychopharmacology revolution, where in the 1950s and early 1960s, there were over 1,000 publications and a considerable academic interest in this area. It was a promising area of psychiatry. There were methodological and regulatory challenges with respect to how to study these types of substances, but there were very promising clinical results, including here in Canada, where we were once a world leader in the area of psychedelic medicine, but it sort of languished after, there was also unethical covert military involvement, much of which is we're still dealing with some of the legacies of that with CIA-funded research in places like Montreal. But it was actually the non-medical use of these substances by the youth and the counterculture elements of the 1960s that really sort of shifted public and political opinion to the point that these substances were prohibited or scheduled in such a way that they didn't do so much to keep them off the streets, but certainly kept them out of the hands of scientists and doctors, in a way that Dr. David Nutt, a psychopharmacologist from the UK, has characterized as equivalent in the history of science, perhaps only to the banning of telescopes by the Catholic Church in the 16th century. That we've kind of lost the equivalence of knowledge in the last 40 years by refusing to engage in clinical scientific research with these molecules. Fortunately, we've turned a corner. There's a sort of new renaissance happening. This CMAJ article is just part of that, illustrating the increasing legitimacy and acceptability of engaging in a sort of careful, circumspect study of these substances, to the point where the U.S. Food and Drug Administration has declared breakthrough therapy status for both MDMA, methylene dioxymethamphetamine, or the drug ecstasy or Molly as it's known on the streets, as well as psilocybin, the active ingredient of so-called magic mushrooms. In addition to the clinical research that's leading to these highly exciting results for therapeutic breakthroughs, there's new analyses and healthy subject and population studies showing correlations of psychedelic use with reduced addictions, suicidality, criminality, and recidivism, and increases in things like personality domain of openness, increase in optimism, nature relatedness or kind of ecological orientation, spirituality, and divergent thinking. The spirituality piece is interesting insofar as it is resonant with the traditional indigenous knowledge practices involving these substances, as well as the correlations that are being demonstrated between the sort of therapeutic outcomes that are achieved with having a mystical or spiritual type experience during a session that can really be transformative for people. So where are we going in the future? We're now moving into phase 3 clinical studies, which is sort of the next phase that's required to bring to regulatory authorities such as Health Canada or the US FDA to approve these drugs as legitimate medicines. And it's not just the drugs themselves, it's this package of the psychotherapy piece, and this is largely what our panel is going to be speaking about today, is the blend of the psychotherapy with the application of the substance, and the preparation and integration that seems very critical for achieving these kinds of therapeutic outcomes. And then down the road, next generation questions such as concurrent disorders, being careful of the potential risks and what patients might these not be appropriate for, as well as potential combination therapies, combining different types of medications or other types of non-drug therapies such as virtual reality, other types of digital health technologies. It seems that the sky is the limit in terms of possibilities now, and explanatory studies using latest neuroscience tools to see how these substances are working in our brains. So with that, I'm going to say thank you and turn it over to Zac to take us into the next step.
Great. All right, thank you very much. So I'm just thrilled to be here to be able to share some research that we've been doing in this area on the potential therapeutic applications of psychedelics and how we can understand what kind of interventions are going to be best suited to pairing with psychedelics, because it's psychedelic-assisted psychotherapy. So we really have to figure out what the psychotherapy piece is going to look like. So I want to talk about that. I want to focus today on violence. That's really where my research background is in. I worked in jails in Chicago throughout my Canadian originally, but did my grad school in Chicago and worked in jails there on violence and recidivism. So I want to talk about those as clinical targets, broadly the externalizing spectrum, and expand that to violence towards the self as well, so self-harming behaviors. Propose a few preliminary mechanisms for how these might work, and I think those mechanisms are important because by delineating those mechanisms, we can start to see, well, how do we do something that's going to be synergistic? How do we potentiate the effects of the psychedelics with therapy? And maybe it's by working on those same mechanisms. And then suggest just a few types of interventions that focus on those mechanisms. And of course, we're not going to get into those in any detail, but perhaps provide some direction if people are interested in doing a little bit more research themselves. So the idea that psychedelics, the psychedelic experience can be helpful for violence, for marginalized, incarcerated populations is not new. One of the first of Timothy Leary's studies back in 1964 was the Concord Prison Experiment. Some of you may have heard of that study, and in that study, Dr. Leary took psilocybin together with some incarcerated men and initially reported tremendously positive results with reductions in violence and recidivism. Rick Doblin, who many of you are probably familiar with as the founder of MAPS, I think it was his dissertation work following up the Concord prison experiment, and he found out that ultimately maybe the statistical approach was not as cautious as it might have been. I'm not doing that. So he found that it might not have been as effective, and suggested that it was really about not having good follow-up. So these men had this experience, but then they were back in the same situation, and there wasn't any kind of post-therapeutic support. So identifying what those supports might be, I think, is crucial, and that's what I want to get at a little bit today. So as we go jump into the future, so this is that first stream of psychedelic research. Now we go 50 years into the future from 1964 to 2014, and work by Peter Hendricks that really sparked my interest on this initial study of recidivism. And he used hallucinogen use disorder because he's using institutional records. So hallucinogen use disorder in this case is really just a proxy for frequent hallucinogen use. It's not really a disorder in the classic way. And this is the likelihood of failing on probation. And I don't want to get too much into statistics here, but if you look at that 0.6, that means that the men, or the people in this case, who had hallucinogen use disorder recidivated, they were 60% as likely as those who didn't have the disorder. I mean, that's unheard of. When do you hear of a substance use disorder dramatically reducing the risk of failing probation? And if you look at some of these other factors here, like having a job, that's something you really want if you have probationers. You want to try to get them some kind of occupation. And having a job was not as protective as having a hallucinogen use disorder. So having a hallucinogen use disorder is better than having a job, at least in this context. And even being married, which is, of course, having a stable relationship can be very protective. But again, the size of the effect is around 0.8. So they're 13% less likely. The hallucinogen use disorder, 40% less likely. So that was wild, and we really wanted to look at it. So I looked at some of the data that I had from the prisoners in Illinois, and we followed them. We have their prospective data for about 8 years. And we looked at, these were people who had substance use disorders, who had that diagnosis, and we looked at their risk of recidivating to partner violence, which is the most frequent form of violence and also the main factor in recidivism in this group. And what you see again, in this case we had hallucinogen use and hallucinogen use disorder. And what you see here is that the men without the hallucinogen use disorder, and this was all men, without the disorder, 65% survived, which means that 35% of them were arrested for domestic violence. And compared to those with the hallucinogen use disorder, only 10% recidivated. So again, a protective effect for having hallucinogen use disorder, and again, just frequent hallucinogen use. And if you look at any hallucinogen use, it's a similar pattern. So really remarkable. It seems that hallucinogen use, perhaps even a single case, but we also see dose response, so the more protective it is, reduces the likelihood of engaging in subsequent partner violence. And we want to see if this extended beyond a clinical sample. So we did a survey with a community sample, and this is university students and adults in the community, and we found a similar effect. We found that amongst those who had used LSD, lifetime use of LSD, 8% engaged in partner violence. Those who had never used LSD, it's 12%. So again, a dramatic reduction in violent behavior associated with substance use. And that's just not what we generally see in the population. Something's going on with psychedelics that seems to be protective for violent dysfunctional behavior. And an advantage we had in this study is that we were able to ask some more questions. So we were able to assess something called emotional regulation, which is a candidate that we thought might be what's going on with hallucinogen use. Why is the psychedelic experience protective? And that is what we found. We found that individuals who had psychedelic experiences had better emotion regulation, and it's that increased emotion regulation that led to reduced partner violence. Emotion regulation is just the ability to have strong emotions and not behave in a dysfunctional way as a consequence of having those emotional experiences. So it's being able to notice your emotions and continue to act in a way that's consistent with your values rather than being fused to that emotion. And it's not just our group. So other studies, this top one here is brand new. It just came out a couple months ago and showed that ayahuasca users also showed improved emotion regulation, and particularly amongst people with borderline personality traits. And emotional dysregulation is, of course, a hallmark of people who struggle with borderline personality traits. Other research from the same group from Spain found that ayahuasca was also associated with increased mindfulness. So mindfulness is closely related to emotion regulation. You can't regulate your emotions if you're not mindful of them. And so these two things are tightly tied, and it could be this combination of mindfulness and emotion regulation that underlies some of the protective effects of psychedelic experience. And the group from Hopkins, that bottom study from just a few years ago as well, from 2018, found similar results. They found that if mindfulness was paired with psychedelic experience, it had better effects in promoting pro-social behavior. So we've talked about inhibiting antisocial behavior. It seems like it can also promote pro-social behavior. So when we take all this together, we start to get some ideas about what might be going on, what the mechanism might be. And it feeds well into some of these therapies that also have a similar foci. So focus on mindfulness, something called dialectic behavior therapy. And it's part of a body of therapies, third wave behavioral therapies that focus on mindfulness. Sometimes they're called mindfulness-based therapies. And DBT focuses specifically on mindfulness and specifically on emotion regulation. So it could be that, if the psychedelic experience is promoting mindfulness and promoting emotion regulation, a therapy that does the same thing, we could get synergistic effects. ACT is another one of these therapies. They use different names for some of the same constructs, but it's very similar. Contact with the present moment. Cognitive diffusion, so being able to observe your thoughts and your emotions rather than being fused with them. So taken together, I think that this shows some real potential for these type of behavior therapies. And the truth is, we don't know what therapy is going to be best with the psychedelic experience. We don't have the trials. I mean, we don't have comparative efficacy showing psychedelic experience with third wave behavior therapies versus psychedelic experience with humanistic psychotherapy or psychoanalytic therapy. This article just came out last year as well, does a really nice job of breaking those down if you're interested. I believe it's open access. And it looks at the psychoanalytic approach where the psychedelics at a lower dose can open people to overcoming some defenses and perhaps greater insights. Humanistic therapy seems to be sort of the dominant model there, where it's people's internal processes facilitated by the psychedelic experience, and people are starting to engage motivational enhancement or CBT. And what I'm promoting is that perhaps behaviorism and some of these newer third wave behavior therapies are another promising option. So once again, it seems like mindfulness and emotion regulation may underlie the effects of psychedelic experience, some of the positive effects. We have therapies that already tap into these constructs. And so the question is out there, and I think it's awaiting empirical support of whether or not third wave behavior therapies are the way to go. But I think there's some evidence they are. And interestingly, when we think of how these therapies were originally developed, they were developed to address suicidal and self-injurious behavior. And some terrific work from the BCCSU group, Eleanor Argento, who's here, and Ken as well, was on this work, showed that psychedelics could also be protective for suicidality. So you see that right up there. 40% is likely to engage in suicidal behavior with psychedelic use. And that finding has also been replicated by Hendrix's group, showing less suicidal ideation and attempts amongst individuals who have used psychedelics. So it's just a beginning, and we're still looking at what's going to be most effective. If you're interested in engaging with some of these ideas in more detail, we've written a paper that outlines it, and the group from the UK has done a really nice job looking at how psychedelic experience and meditation might work together. So please contact me if you'd like more information, and thanks so much for your attention. It's a real pleasure. Joanna, you're up.
So this talk is a tribute to Fatima Ghazla, who has been my mother figure and has given me the opportunity to be who I am today. We have shared a deep trauma together that changed our entire lives. May she rest in peace. The views expressed here today are mine solely and not those of MAPS or BC Centre for Substance Use. And if you feel triggered by anything I shared today, since I will be speaking about trauma, please take some space and time to take care of yourself. First of all, I would like to acknowledge all the hardworking healthcare professionals that are dedicating their lives to helping people heal from mental health and addiction issues. Thank you for all that you do. Trauma-informed practice is not just a catchy phrase that looks good on paper in healthcare policy. It is a non-negotiable practice for healthcare practitioners, as many patients, if not all, are traumatized to some degree. In my hospital career as a social worker, I have seen numerous psychiatrists spending extensive time and effort in capturing the current presentation of symptoms in their consultations with only 1 or 2 lines talking about the past traumatic events, almost like it's a footnote. And by the way, the person was also sexually abused from ages 3 to 5. Instead of having psychiatric consults focus exclusively on symptoms and diagnosis as a reductionist view of trauma, we need to put the traumatic experience as the title of the consults and then consider the symptoms as the framework in order to better understand the presentation and its potential resolution. We have clear evidence demonstrated in the Adverse Childhood Experiences Study, also known as the ACEs study, that this unresolved traumatic imprint of the original experience is at the root of most chronic physical and mental health conditions. Many types of physical and mental health issues, including addiction, stem from a history of trauma. Until the day comes when we fully realize this is when the system has the potential to change and make significant revisions to mental health and addiction treatment. As a trauma therapist, what I have discovered time and time again is that when you go to the depths of disorders, such as depression and anxiety, you will find internalized negative core beliefs that drive the emotional dysregulation in the nervous system and the default mode network in our brain. These negative core beliefs are loaded with emotional and physical sensations that activate the polyvagal system with the interchange of the autonomic nervous system, with the activation of the sympathetic nervous system, which shows up as fight, flight, and high freeze, and the parasympathetic nervous system that shows up as low freeze, shut down, submit, feign death, and dissociation. We also see the interchange of the ventral vagal system, the social engagement and attachment system, as well as the dorsal vagal system, which consists of presentations of depression, numbness, sense of disconnect, and shame. What we are seeing are the diverse faces of trauma in their various presentations of symptom clusters rather than actual disorders. It's time for us to face the collective unconscious shadow of the mental health system. Since the system cannot look at itself and see the flaws in itself, we have to acknowledge the shadow of the system and the huge profit made from keeping people sick and dependent on a broken system, with medication as the only form of treatment, creating short-term relief and a long-term addictive pattern with no resolution. Because if the system would actually have to face itself, it would realize that it needed to change immediately, since people are not getting better, and many are actually dying, as we are seeing in the opioid crisis. Upping the dose isn't going to change the prognosis when it comes to mental health and addiction. In my opinion, the dark side of the system doesn't actually want to change or heal because it fears that it would be annihilated and there are many stakeholders in keeping the status quo. However, based on my experience, the masses are getting tired of the med cocktail and hopelessness, as I see in the clients I see in my practice, and are looking for real solutions. So it's just a matter of time before the paradigm shifts. I've worked in emergency departments as a social worker for years, and I've seen many patients coming in for panic attacks, anxiety, suicidality, overdose, psychosomatic symptoms, substance intoxication, and other mental health crises, which are all symptomology of trauma, as shown here based on Janina Fisher's work. Wouldn't it be easier if for everyone, if these individuals had more appropriate places to go, other than getting so far into the crisis that they had to resort to going to the hospital because they couldn't bear it any longer? Instead, they walk away increasingly hopeless, traumatized by the way they were treated, and powerless, feeding the vicious cycle of trauma, and eventually making their way back to the ER, asking for more help, continuously dependent on the system that can't actually provide long-term relief. In my work in the ER, I have witnessed patients pleading at the door that if they get discharged, they will likely commit suicide, while psychiatrists escort people out with security due to being disruptive, shutting the door in people's faces. How are these ethical practices? Seems like very stressed and burnt out psychiatrists due to the systemic challenges we collectively face as healthcare practitioners. I have witnessed women having their clothes torn off their bodies by multiple security and hospital staff without the consideration for earlier sexual assault history, some as early as within the year of the incident. I have seen patients bullied into taking medication by the nurses and doctors. I have seen patients shamed for being transgendered and staff refusing to use the appropriate gender pronouns. The mental health and addiction system itself creates a stigmatizing otherness where the nurses and the physicians are segregated from the patients, whether it's through nursing stations, seclusion rooms, or restraints, creating an emotional segregation with a clear division between us and them. No different than prisoners and security guards within a prison system. What does that do to a patient who is already feeling less than and hopeless? It keeps them disempowered and feeling unsafe. I've worked in the local emergency department providing psychiatric care, where the common treatment for borderline personality disorder was borderline therapy. This therapy including getting the most uncomfortable chair in the hospital so that the patient would leave the hospital with the hope that they would never come back. Even the mental health and addiction staff are traumatized because they are working in a system where they see people suffer continuously, and all they can try to do is manage their pain without any changes. It's a hopeless ordeal, and staff end up calling in sick or going on sick leave due to the stress of powerlessness and hopelessness that is a key signature of trauma. The revolving door system creates overwhelmed and burnt out individuals who initially started as kind helpers but had to resort to protective mechanisms of hard armor and numbness against the revolving door of patients coming back to the hospital or outpatient clinic complaining of the same symptoms or increase in symptoms, for which they are given more medication that is not working and has horrible side effects. We pathologize patients for their suffering and re-traumatize them while in our care, and then send them back through borderline therapy and waiting room hoping they will never come back. How is this working for us? Why would we want to punish these patients, shame them, abuse them, neglect them, reject them? Aren't we just reenacting their childhood experience with them, making them feel like bad, worthless children all over again? How can we be so blind to the suffering of others? If we exercise a more trauma-informed perspective, these patients will be welcome into the hospital with staff knowing that this person just needs a safe place to land, a place to get some relief from their inner turmoil, a place to be temporarily safe, a place where they could interact with a professional who could assist them in stabilization with kindness. I'm going to skip through some of these slides, but I would encourage you to take note of some of these psychiatrists that I'm showing because they are doing some really innovative work with trauma and the brain. Why is the field of trauma and attachment research, as well as interpersonal neurobiology, so detached from psychiatry? How do we reconnect psychiatry to the field of trauma? I believe it's through psychedelic medicine, since these medicines have shown us the root cause of the symptoms, which always goes back to some traumatic experience, usually in childhood. We have to do better. These archaic aversion practices, therapy practices in our ERs have to go. We are in a mental health crisis. We can't maintain managing symptoms anymore. We need real solutions. We need healing. We need connection. We need psychedelics and psychedelic therapy, respect, integrity, and compassion. We need to bring love back into the healthcare system, like Jota for physician would say. So one of my private practice clients was hospitalized in a mental health unit in a local hospital after being taken against her will and certified for what appeared to be psychosis NOS. If the physicians were aware of trauma-related dissociation and the symptoms of structural dissociation, they would come to understand that her presentation is rooted in trauma and not psychosis, and that the voices in her head are actually fragmented representations of her dissociated self due to childhood trauma. Instead, she was placed on antipsychotic medication for the first time in her life, ordered to see a psychiatrist weekly to manage her medication, and the best part was nobody called me to consult about her well-being, despite me having worked with her for close to a year. According to the family, the psychiatrist's comment when they mentioned me was, "What does she know about this situation? She's not a psychiatrist." The client's never been diagnosed before for anything other than anxiety. She returns home after a month of being locked up in the hospital against her will, while being heavily medicated on very serious medication, only to find out that the college of her profession penalized her for getting hospitalized after receiving records of her pathologizing misdiagnoses from the diagnosing psychiatrist. She then gets increasingly stressed, making her trauma symptoms worse, and we lose about 6 to 8 months of trauma work, having to go back to the basics of setting up housing, making sure she keeps her job to stay financially stable, while ensuring that she doesn't decompensate and start the wheel spinning all over again. How is it that our mental health and addiction system is setting people up to fail just by a person crossing paths with it, sometimes against their will? Okay, I'm gonna wrap up because I realize we're out of time. So healing is not just a quick fix. It's a way of life, a way of being. Many people have the assumption that if I just take a little MDMA, I will be cured. From my first-hand experience working with this unique medicine, I can tell you that it's not like that at all. MDMA is a powerful agent on its own. However, coupled with psychotherapy, creates a profound opportunity to heal deep traumatic wounds at the core. MDMA helps to open up the heart through a release of oxytocin so we can feel connected through the social engagement part of our brain and nervous system, also known as the ventral vagal system through Stephen Porges' work. It reduces the activity in the amygdala, which shuts off the threat response, in which most people with PTSD would trigger a fight, flight, freeze, or shutdown responses when triggered long after the event has passed, and in some cases leads to various levels of dissociation, which is drop in consciousness. The amphetamine in the MDMA activates our executive function in the prefrontal cortex, including the medial prefrontal cortex, so that we may be a witness to our experience, creating the connection to ourselves. It also gives us access to our logical, analytical part of our brain in the prefrontal cortex in order to create the necessary neural connections to adaptive information, to create new understanding and realizations, move into acceptance and reprogramming new functional narratives and empowering core beliefs around the past traumatic experience. The MDMA assists with memory reconsolidation of being able to pull up old memories of trauma from our working memory and undo emotional learning that solidified the traumatic imprint in the brain to make the memory more malleable to change, giving permission for a new narrative to be formed, offering an ending to the story of what happened, and finally putting the past in the past with a date and timestamp given by the hippocampus, our long-term memory storage. Once the past is actually perceived as in the past, then the person gains clarity to what is happening in the moment rather than reacting to a past trigger as though it's happening right now. The individual can transition to live fully in the present moment without anticipating the next sudden trigger coming out of nowhere, taking the person into major overwhelm with hyper and hyperarousal of the nervous system. So I'm just going to wrap this up. Preparation and integration are very important aspects of the psychedelic psychotherapy work. Without these pre and post pieces, the MDMA experience is simply just that, a wonderful and uplifting experience. Sub-participants who are coming to us as part of the study have never had the experience of being in a non-ordinary state of consciousness. Thorough preparation for this heart-opening experience is essential in supporting the individual in getting a sense of what to expect for their first encounter with the medicine. It allows us to review the risks and benefits, discuss the impact of the MDMA on the body and brain, share what we have seen in other experimental sessions to help the participant ease into the process, and discuss what is generally expected in terms of this session. We are overdue for a paradigm shift. We can't afford to wait much longer due to the state of our world. We cannot continue the institutional denial of childhood trauma. We have to see the symptoms of addiction and mental health issues as symptomology of trauma. We cannot continue to shame and blame our patients for something that wasn't their fault just because we experience compassion fatigue due to our broken system. We need love and compassion to soften the hearts of those practitioners working in the mental health and addiction system to see the human being that we call our patient. This is the way we break through the powerful entity that we call the mental health and addiction system that has a life of its own and seems stubbornly impossible to transform or shift. The psychedelic medicines teach us about love and compassion for our fellow human beings despite the professional roles we play. We recognize each other as family rather than strangers and are more capable of opening our hearts rather than seeing the patient as the other. We are more genuinely invested in the collective healing of other human beings if we connect on a more intimate level with each other. It's time for a paradigm shift, and that shift is introduction of psychedelic medicine and psychedelic psychotherapy as a potential adjunct solution. Thank you.
Well, thanks, Joanna. That was really moving. I appreciate all of that, and thanks, Zac, for that interesting data on how psychedelics affect some large-scale social issues. How's everybody doing? Good? Okay. I'm going to get oriented here. So my name is Nitasha, and before I get started, I would also like to take a moment to acknowledge the land on which we are gathered as the unceded and the stolen territory of the Coast Salish, the Squamish, Tsleil-Waututh, and Musqueam nations. And I thank them for the stewardship of this land, as well as stand in solidarity with decolonization. In addition, I'd like to thank and respectfully acknowledge the Indigenous and female knowledge holders who have engaged in healing processes with sacred plant medicines and sacred ceremony for centuries. Although they're not invited to speak here today, I hope that we can collaborate with equity as we start to look at how to integrate psychedelic-assisted psychotherapy in our dominant healthcare systems. And I kind of want to share a little piece of life experience around this too, because I know I've been saying this land acknowledgement and these acknowledgements for some time now, and I kind of sat and said, what does that really mean? Like, what does it actually mean to stand in solidarity? And I want to share a little pearl, which is, I asked a colleague of mine what that really means, and she said, well, you're preparing a talk on equity. Why don't you consider, sharing some power and privilege? Why don't you make a donation to a community organization that's advancing these ideas that you're going to be presenting on stage today? And I thought, well, that's something. And so I did that for this talk today. I will be speaking about ideas of intersectionality and power and privilege, et cetera, and I made a donation to an organization that works for that. So something to consider as we advance these conversations of standing in solidarity, decolonization. I have no commercial or financial conflicts. It was mentioned I am the PI of a study sponsored by MAPS, And really, I want to say I'm no expert on the topics I'm about to speak about. I'm learning along with all of you, and it's a process of self-reflection. So I encourage really great questions and challenging questions as we go into this conversations. So I was tasked today with speaking about the challenges and opportunities in the advancement of psychedelic research and policy change. Those are the words I was given. And although there are so many beautiful opportunities and challenges, we're talking about an entirely new therapeutic model for healing that's rooted in centuries-old traditions. I mean, there's a lot to really explore, and there are many challenges there. I thought I'd focus on justice, equity, diversity, inclusion in the Renaissance, because we're really at the beginning of it from my vantage point, although lots of people have been working. We're kind of at this beginning point of integrating it into the dominant healthcare system, and we have a chance to build an equitable system from the get-go versus looking at things that we've done and criticizing them later. So there's something there as a challenge and opportunity, and then just want to speak a little bit about the system of drug scheduling. I'm going to talk a lot about these words of intersectionality, identity, power, and privilege, and so I thought I'd take a moment to define them a little. Kimberly Crenshaw has defined this idea of intersectionality, and essentially it's about looking at axes of identity and how they interact on different levels to propagate social inequity. And the privilege is really that power and that social power that's gained based on membership in a dominant social group or a dominant social identity. So that's what I mean when I use some of these terms. Again, throwing a lot out there because we'd have limited time and hope to flesh it out as we talk more. So let me give you an example of this. What am I talking about? Well, recently this group, Michaels et al., came out with this paper about the inclusion of people of color in psychedelic-assisted psychotherapy, a review of the literature. And they looked at 282 people that had been involved in psychedelic trials, and they found that on this particular axis of identity of race, there was a significant disproportion, of over 80% of people identifying as white. Now, we know that that's not the dominant North American population of people that could have potentially been recruited into the study, and definitely not the population that experiences, the only population that experiences trauma. So there's a disproportion here. That might lead us to ask, well, what exactly is going on? Is anyone else asking that? I know some other scholars have been asking that, and a lot of community groups are asking that, and a lot of people working in psychedelics are asking that, because not only are those proportions just in the participants of research, they're probably in therapy teams, they're probably in research teams, they're probably in policies, they're probably in people who are making the drugs. That disproportion is probably sort of reflected widely across the psychedelic renaissance right now. And so you ask, what are the barriers to including people or gaining access to this psychedelic therapy? Lots of folks have tried to look at those. I'm going to quickly kind of skim through that, but I encourage you to look up these resources or come to me. I'm happy to share them with you after. So Wahid et al. Has sort of looked at them in a category of 5 things: participant-related barriers, practical issues such as lack of childcare or transportation. Participant are related to things like trust or stigma, other axes of other identity, family-related, health services-related, research process-related, things like where is the research site located, how are people recruited, how is the study accessed, is it via phone, is it email, do people have to have literacy, all these sorts of questions. So there's a whole big complex set of things to consider around barriers to access. And then there's also larger and historical phenomenon of oppression, and that's what Monica Williams talks a lot about. She looks at perspectives of historical violence and exclusion in research trials, how we use diagnostic criteria and inclusion criteria that pathologize people of various cultures and backgrounds and walks of life. She talks about the racist war on drugs, and these are just larger phenomenon. So really, again, complex, not much time to really talk about that complexity in this talk, but it all lies at the center of these overlapping circles, and this Venn diagram could be much bigger, I think, but it's at the center, and that's where I think the work lies, and it's about equity, and it's about understanding how they all work together and finding new ways to build up our system. So how can things be more equitable? Again, looking to some of the early literature by Wahid et al., they kind of looked at different barriers according to those 5 categories, and I've just highlighted a couple of the things that they, in terms of summary of proposed strategies for including people of color, although this could be applied to all walks of life and other axes of identity, into research. So they talked about language, transport, financial things, how we design our studies, and how we train people who are participating in this research and in this therapy eventually down the road. One of the things that really struck me is, the lack of culturally competent staff was something that was across multiple studies. And we think we're really trying, we're learning, we're doing all this stuff, reconciliation, but it was still something that came up as one of the major barriers to inclusion. So I think that's something for us to reflect on. Mackenzie et al. Is a Canadian group of researchers that looked at barriers to health access, and I think they kind of mirror some of the same things about barriers into research. So overall, examine power and privilege, access and equity across all the factions of the psychedelic renaissance is something that is a really beautiful challenge and a really beautiful opportunity. We're talking about medicines that have the potential to heal. It's a different approach, I think, to how we talk about addiction and how we talk about healing. And I really hope that we can look at all these things as we build it up. And remember, it's all a process. It's always changing. And so not to be hard on ourselves or others, but to try to continue to generate conversations and learn and be thoughtful and really acknowledge things with our hearts. So how do we go from an ancient wisdom to an inclusive future? That's one great challenge and one opportunity. And I really love this visual. I want to spend a few minutes or a moment talking about it because I think we talked about system building from an equality perspective where we gave everybody the same resources, but we found that kind of still had access issues or, diversity and inclusion issues. Then we're moving to things like equity where we give different people different resources in hopes that that might even the playing field or improve access. But maybe one day as we build this psychedelic renaissance, we can look at something like liberation, where we design a system where nobody has to be the gatekeeper of resources and who gets what, but rather we remove the barriers in and of themselves and we design something differently. So as we move forward, as we're talking about a healing modality based on Indigenous traditions and knowledge, how can we go toward liberation, even beyond equity? So shifting gears a little for the last few minutes, the second challenge and opportunity that I thought might be worth highlighting is policy and regulation. And I mean, this is not specific only to psychedelics. This is something I think that's come up throughout this conference, which is the fact that these particular drugs are under the Controlled Drugs and Substances Act. They're not drugs, actually. I want to call them substances. So these substances are under the Schedule 1 and Schedule 3, which means you can't possess them, you can't have them, you can't traffic them, and if you do, you got to pay fines, you got to be in jail. So really makes it hard to work with them, It's hard to study them. There's a lot of people that kind of risk their lives to access underground therapy or provide underground therapy, given how restricted these substances are. And we're looking at them as medicine, as sacred therapies, but the government sees them as things to be criminalized for. So that's definitely a challenge that we have moving forward. There are some people trying to address these challenges. So, for example, looking at these substances as medicines, some people thought, well, maybe we could get access to them via the Special Access Program, which is sort of a loophole of allowing medicines to be available, even though they're not generally or widely available for sale in Canada. It allows special consideration, so a practitioner could apply to have a psychedelic medicine like MDMA available to be used in a particular setting. Unfortunately, the Special Access Program has this line that says a restricted drug as defined in Part J is not eligible for authorization by the SAP. And guess what falls under that? All the psychedelics. So we have some folks, I think Dr. Tupper is one of them that's been working on it, to try and remove that line out of the SAP so that maybe in 2020, when hopefully MDMA is potentially available, we can apply for it under the SAP because it can be seen as a medicine. So that's some really interesting, I think, opportunity. In addition, there's a fellow named Bruce Tobin who's applying for the use of psilocybin to be available at the end of life using one of the exemptions that we have under the Controlled Drugs and Substances Act, which is the Section 56 exemption. I hold one of those to be the PI of these trials, but unfortunately that's the only precedent set in Canada right now to be used for research. Wouldn't it be great if we could try to get these exemptions for certain indications in therapy? So what's the future state and ideas? I hope we can discuss that in the panel. Will these substances and medicines be decriminalized, legalized? What could psychedelic psychedelic therapy and research look like with respect to justice, equity, diversity, inclusion? How can these sacred medicines and healing traditions be evolved, advanced, brought into the dominant healthcare system with access for as many people as possible as we build up a new healing modality? That's all up for discussion today. And again, I'm really just here to learn from everybody. I really appreciate your attention and your ideas and invite you to come up to the mic. Thanks.
All right, well, good afternoon. I was very inspired by Zac's information about work versus psychedelics. I'm writing a book right now, and 2 books actually, and next Thursday I'm flying to England for a speaking trip, and after that I'm going to Peru to lead a retreat with ayahuasca in the jungle. But after I heard Zac speak, I decided, give all that up. I'll just stay home and do some mushrooms, and I'm sure I'll be a lot more rested as a result. I really appreciated the very vivid picture that Joanna painted of our system. It's astonishing to me, I have to tell you, that there's a addictions substance use conference without a single lecture on trauma. That itself is indicative of how not broken the system is, but how clueless the system is. Because there's not a single person, any of you, there's not a single person any of you will ever treat, interact with over substance abuse issues that were not traumatized. It's that trauma that we know from brain science actually shapes and misshapes the circuitry of the addicted brain from early childhood onwards. That's not controversial. That's just brain science. It's also the trauma that destroys people's sense of self, that makes them want to escape from the intolerable discomfort of being with themselves the way they are. And it's not, and given that we're speaking of intersectionality, it's not by accident, by any means, that if you look at the downtown east side of Vancouver, 30% of the people living down there and addicted are First Nations origin, whereas First Nations people make up 6% of the Canadian population. Do we think that's an accident? Do we really think it's genetic? No. They just happen to be historically and continually and into the present the most traumatized segment of the Canadian population. And study after study after study after study has shown this, and it seems to make no impact on psychiatric practice. And even at this conference, not a single lecture devoted to trauma and its impact on brain development and the human psyche. Well, I was asked to give expert testimony at a trial a few months ago about a person with an addictive history who had killed somebody. 3 psychiatrists had examined the guy. They all reported he had a happy childhood. This is after 4.5 hours each of forensic examination. I talked to him for 45 minutes. This happy childhood included having his arm broken by his brother, having his hair set on fire by his brother, having his father be an alcoholic, being bullied in school, and having nobody to talk to about it, and his mother having cancer. That's how clueless the system is. Now, why do I mention this in the context of psychedelics? Because Zac, I think, very appropriately laid out some of the mechanisms by which the psychedelics may do their work. And all those mechanisms, the more presence, the self-regulation, emotional self-regulation, nobody's born with emotional self-regulation. A baby does not have emotional self-regulation. Those circuits have to develop in the limbic system and in the prefrontal cortex. They develop in interaction with the emotional environment. In situations of trauma, that development does not happen. So really what Zac is describing is the reversal of traumas through psychedelics. And I've been working with psychedelics now for 10 years now. And almost accidentally, really, because once my book on addiction was published, and if you don't understand the relationship between addiction and trauma, I urge you to check out that book. When I say check it out, I didn't say to buy it. You can actually check it out at the library. But do read it. And people kept asking me what I knew about psychedelics and the healing of addiction. Of course, being a well-trained physician, I knew nothing. And then I began to find out. And I can tell you, studies or no studies, and there's plenty of them, but in the last 10 years, I've seen people give up opiate addiction, cocaine addiction, cigarette addiction, alcoholism, sex addictions, and lead much more regulated, meaningful lives as a result of their experience with psychedelics. But not just a result of taking psychedelics as such, but in doing psychedelics, and it doesn't matter which one. My main experience is with ayahuasca, but not only. But doing in a context, and Joanna was talking about this, doing this in a context that is actually respectful of their human selves. And as Zac mentioned, with the psychedelics, they can go into the unconscious. They could actually recover, literally recover memories that they had repressed of deeply painful experiences that without their conscious awareness is what they were trying to run away from all their lives through their addictions. But they were able to go back to these experiences as adults with the awareness of an adult and supported in a compassionate way by people that could hold them in that space and guide them. And it's that holding and it's that guidance and the opening that the psychedelic provides that actually leads to the potential healing of the trauma. The other thing that happens, and as Ken mentioned in the beginning, that psychedelics have been used for hundreds and perhaps thousands of years for spiritual purposes. Now, what does that mean? It's not to have funny hallucinations. It's not to have visions. It's actually, and how do you put this in research terms? How do you do double-blind study on God? But it's actually to put people in touch with their deepest human selves, which really is connected to everything that's out there. So that sense of unity that people seek, that is so fraught and destroyed and really trod upon in this materialist culture, that sense of a true self that is united with something much larger, whatever you want to call that. That's also a potential benefit of the psychedelic experience. So really it has two aspects to it. And I'm painting this in very broad brushstrokes. One aspect is that you get to actually work through your trauma. And it's not unusual for somebody to say to any psychedelic therapist, and I've seen this myself over and over, people say, this ceremony or this 3 sessions were like 20 years of psychotherapy. That's just how it works. Now, specifically, I'll mention a psychedelic to you that we should be employing broadly in this province if people are only knowledgeable about it and highly trained in it, only under such circumstances. But do you know, if I told you that there was a plant that somebody could take and give and get a derivative of and give to somebody who's been on heroin for 20 years, and within 1 day they would not have withdrawal symptoms from heroin, would you not want to explore that? There is such a plant. It's called iboga. It's an African plant. It's used ceremonially by tribespeople there, but it does have this quality of absolutely interrupting the opiate addiction so that you don't have to put somebody on Suboxone and they don't have to take methadone for the rest of their lives. Why isn't this more researched? I've seen it. Many people have seen it. So that there's this whole area. And with the ayahuasca, well, that can't interrupt an opiate addiction, but it can certainly help you heal your trauma, as can the MDMA, as can the psilocybin. Again, in the proper hands. Now let me finish with a few words of caution. First of all, psychedelics will never be the answer to mental health issues or substance abuse, substance use disorders. When I say they'll never be the answer, I mean they'll never be the answer, because the number of people trained in it are always going to be small, number one. Number two, it's highly time intensive. 2 therapists for 6 hours for one client. Or in the case of ayahuasca, 20 people with many staff to help look after them. But they'll also never be the answer, because we should never look at the answer to addiction in the treatment system in general. The answer to addiction lies in the social conditions that engender addiction, in the child abuse, in the criminal justice system, which criminally abuses the people that it's supposed to look after. It's a criminal system. It's a well-named criminal justice system. In the schools, where children who are troubled, mentally dysfunctional, are ostracized and punished rather than compassionately understood and treated. So in the racism that still blights this country and so heavily weighs upon our indigenous population specifically, in the inequality, we know that the more inequality in a society, the higher the rate of addiction. So we always have to look beyond. Whatever we do personally or as a profession or as professionals, we have to look beyond just the treatment and look at the larger social issues that drive the problems we're trying to solve. And finally, let me give you a word of caution. Today there's going to be a statement issued by MAPS, the Multidisciplinary Association of Psychedelic Studies, because 2 therapists in BC, a psychiatrist and her partner, a psychologist, were involved in the MAPS MDMA study, and the psychologist became sexually involved with one of the clients, a highly traumatized, PTSD-burdened individual with multiple head concussions. Now, MAPS is going to issue a statement today publicly announcing that they'll no longer work with these 2 people. But these 2 people still run an institute on Cortes Island called the Arenda Institute. And they're still offering training to train people in psychedelic psychotherapy and shamanic practices. I urge everybody who wants to undergo such training to consider that before you undergo such training, make sure who you're working with and decide for yourself who you actually want to learn from and who you may not want to learn from. So in short, the psychedelics provide a terrific potential to help a lot of people, but we do have to be cautious about their use because they make people very vulnerable. And we also have to look to the larger social issues that drive the problems we're trying to solve. Thank you.
Thank you, Gabor, Zac, Nitasha, and Joanna. So we have about 20 minutes for Q&A, and there's microphones on the aisles. If you have a question for one or all of the panelists, please come up. And if you can introduce yourself with your name and any affiliation, that would be great.
Hello. My name is...
thank you.
My name is Danielle Diggle, and I'm a nurse practitioner that works in Campbell River. It came up earlier because I think this was talked about at the Western Canada Addictions Forum as well, and it was just an interesting question. It's not my question, but I'm going to ask it on behalf of my colleague. Can you speak to the side effects? So, if people are using these and then Because I know that in some instances, the flashbacks and that kind of thing can be an issue. So can you just speak to the side effects of these?
Yeah. Now, is this mic on? Okay. Well, first of all, the people that enter such therapy need to be screened. So if there's a past history of psychosis or manic episodes, you really want to be not taking them on, because you won't have the capacity to hold them if they do flip out. In terms of long-term side effects, I'm not aware of too much in those people that are screened properly and are given these substances in a proper context. But I've seen occasionally people become either manic or psychotic as a result of some of these substances. So the screening has to be very, very careful. What can happen is that immensely traumatic memories can arise and immensely frightening emotional states can be experienced. That's okay, as long as the context is safe and well guided. That's not a problem. Actually, you welcome that.
Is this on? Okay. So in our phase 3 clinical trials, we do extensive screening. We want to make sure that it's safe for everyone, and that includes any kind of current substance use, including cannabis, and any other medication that people may be on, because we want to make sure that there's no contraindications, and we have physicians that are working on our team to ensure that. I know with MDMA, one of the concerns is around heart complications, so we do check for an ECG and get a cardiologist to review our readings to make sure that this person is okay, fit to take the MDMA. So we do take those precautions. I know that when it comes to other psychedelics like LSD and mushrooms, it's a lot of a gentler medicine to work with. And speaking about that, we also want to make sure that people are not on SSRIs when they're taking the MDMA, because the MDMA has serotonin in it that gets released, so we don't want to be mixing it with antidepressants as well. So we do very thorough screening to make sure that we are working with participants that it is safe for them to take the MDMA.
Oh yeah, and I should also say that the iboga specifically can be cardiotoxic. So in people who are susceptible, so that needs to be screened very carefully as well.
There are also some minor side effects that can happen as a result of ingesting some of these medicines, things like headaches or jaw clenching, sleeplessness, fatigue, things like that. And although many of those side effects tend to resolve within less than 24 hours, we do also try to screen for people who may be medically have a bunch of other physical symptoms or physical conditions that could interface with those minor side effects. So we try not to take folks who might have severe chronic illness or severe physical disease that may be at risk of having a little extra tip off with something like a headache or jaw or any of these other side effects.
Thanks. We have another question.
Hi, my name's Andrew Gray. I'm a public health physician in northern BC. Just thinking about the question raised about justice as we do this psychedelic research. So we initially heard about how a lot of these psychedelics have been developed, and the techniques for their use have been developed through shamanic practices by indigenous peoples all over the world. And now it seems like as we're starting to do research, we're putting it into this Western scientific psychotherapeutic paradigm as at least so far, seemingly the only legitimate way to use those medicines. So how do we account for that still existing wisdom and practice, and how do we also help that type of practice become sanctioned as we do this research? Which maybe there's a tactical reason to only put it in a narrow box to start while it's still criminalized. But yeah, I'm interested in your thoughts on that.
Yeah, I mean, I'm happy to take this one. The challenge, I think, is that our Western biomedical system, the paradigm, especially in the last 50 or 60 years, is around the pharmaceutical industry, working with white powders, using randomized control trials to determine therapeutic efficacy. And the idea of traditional indigenous knowledge having anything to contribute to our healing practices in contemporary societies, just part of the legacy of colonialism, just disregarding all of that. So I think it's incumbent upon us to recognize that those traditions have so much that we can learn from, and to be respectful, not to culturally appropriate, but to be respectfully asking for that healing knowledge to be shared, and to, I don't want to throw out the idea of applying Western scientific methods, and that is happening, but to be, as I say, be respectful. And I characterize traditional indigenous healing practices as entheogenic healing compared to psychedelic medicine. So a lot of the research right now is working with clinical settings and white powders, but there is research also going on in traditional settings to look at the therapeutic effects with the traditional indigenous knowledge practices.
And I would like to add to that along with my colleagues in the psychedelic psychotherapy field, I mutually see a vision of psychedelic clinics where we incorporate shamanic practices and shamanic healers and practitioners into psychotherapeutic models, so that the clinic could be a place where people are warmly greeted and treated with kindness and collaboratively making decisions about healthcare, about their healthcare and their well-being, and that they have a choice of different options, like anywhere from massage, acupuncture, singing circles, various psychedelic options of therapy and shamanic context, mindfulness classes, dance and movement, yoga, somatic work, neurofeedback, EMDR, hypnosis, energy work, nutritional consultation, aromatherapy, I mean, you name it. How do we bring that all together so it's not just one lens we're looking at? And supporting our indigenous communities in that, and being able to offer them a space where they can share these gifts with us, because that's really, really important, right? To be able to respect where they originally come from. And I think these clinics would reduce the volumes we see in our emergency departments. And I think that, take this vision a step further, I would say that these services would be available to people under MSP, including the most marginalized population. So that would include treatment for a downtown east side population. That's the vision that I hold for that.
I really like what Joanna said in terms of visioning. I think that's where we can all come together and have heart-centered conversations. And it's also about centering different, like the shamanic practices. Sometimes we center the regulatory practices more than that. And we can choose what to center and when to center it. So as we move forward in all our different roles, sometimes you're gonna have to center, getting that regulatory piece for Health Canada, and sometimes we can center, and hopefully we do all these things and we center those conversations, and then we create these visions, and we start to see what it could look like. We start to see what it could look like with everybody's voice and power and privilege, and we then say, okay, who can implement this? Who can implement that? Who can implement that? How do we all work together to vision this new thing and make it happen? Do we need it MSP covered? Do we need a different kind of research that is brought to the forefront? Do we need something else that we haven't yet thought of? So that, I know it's not concrete maybe, but I would offer that as continue to ask that question, continue to center it, and hold it as you walk forward in whatever capacities you have, whether it's bringing that to people who might be in certain roles or whether it's doing it yourself. Keep holding it and centering it.
I think that if I can add just one thing, I hope that, in addition to finding ways to integrate psychedelic psychotherapy to extend sort of the reductionist paradigm that Joanna did such a good job of describing, maybe this can go beyond psychedelics, and maybe as we work the psychedelic paradigm into the broader system, it can have ripples throughout the whole system, so that it won't just be about how do we fit in psychedelics, but how do we renovate the entire system using what we learn from this new paradigm.
Thank you. Question here?
Good afternoon. My name is Jerry Bemister. I'm an academic and the owner of Ravenswood Consulting. My traditional name is Ina Tawaki, given to me by Blackfoot elders. To give some personal perspective, so I'm a recovering addict. I was diagnosed with substance use disorder, and I'll have maintained long-term sobriety this June of 15 years. And I maintained that through Western practices, through spiritual practices, reconnecting with my traditional roots and culture, which played a huge role. And when I'm also a childhood sexual abuse survivor. So in all of that, I've done many of the things and almost all of the things that you mentioned in terms of the holistic, the nutrition, all of those things. But I guess my question is, coming from that lens, is when I'm working with clients who are significantly addicted, maybe mild trauma, like how does this fit in? Because for myself, like if I try to picture continually working on my trauma through this paradigm, like I'm really trying to open up my mind to this because I really feel that we need more solutions. So I guess my fear and my concern and my question is how successful have you guys been with people who have been diagnosed with substance use disorder?
Substance use disorder when it comes to psychedelic psychotherapy research?
Well, let's ask a more general question is, first, how successful are we, period?
Okay.
What is our success rate? 5%? So we know that this paradigm doesn't work. So we have to be bold in looking for and exploring new paradigms. Number one. Number two, we don't know yet because we haven't, well, we know from Latin American studies. I mean, those studies have been done. Say in some countries, ayahuasca, for example, is not illegal. And in Brazil, they actually give it to people in jail to help them regulate, not as a sedative, it's not that they take regularly, but they have ayahuasca sessions as a way of helping to gain self-regulation, as Zac said. And we also know in regular uses of ayahuasca, and Zac gave some statistics in general, there's less substance use, less depression. So we have evidence. Now, we don't have a model in North America yet where we've given these substances, I shouldn't say given them, offered these substances to large numbers of people in a safe, supportive, psychotherapeutic environment. So that I don't have a statistical answer to your question, but I do know, having worked in the downtown east side for 12 years, how the system is not broken. That's not even the right word. It's, as I said, it's completely misguided. But I've seen, just for myself, I've seen how successful it can be over and over and over and over again. That's not statistics, but that's my personal experience. And you know what? I'm 75. I'm not going to wait for all the statistics to come in. I just don't have, I don't have that much time left on this earth to wait until all the double-blind, et cetera, stuff comes in. So given that the current paradigm is an utter failure, given that we've seen promising results in so many places, I say we need to be a bit bold about our exploration.
If I could say something. Another clinician, Dr. Evan Wood, I've heard him say something that has stuck with me that might offer something in response to your question, which is sometimes we see folks that experience severe substance use disorder and symptoms of it, and they have this aha moment, and they enter recovery. Sometimes it's a spiritual awakening, sometimes it's the birth of a child, sometimes it's something else. But there is a cohort of people that seem to be able to have this experience that transitions them into a new phase of their life where they're not using the substances. And so Dr. Wood suggests that perhaps the psychedelics have the capacity to bring that type of experience to someone that may create that aha that transitions them to a new phase. So again, I don't know that we have that, but that's possibly something that could leave you with that's how it might be effective. Okay. I'm sorry about my mic.
Yeah, and just to add on to that, so what we have seen in the research, in psychedelic research, is that things like, for example, LSD have been shown to be effective with alcohol use disorder or smoking cessation, right? We have seen people who have mystical experiences after psilocybin, sometimes even just one session, and recognize that maybe they don't want to continue with their behaviors anymore, right? So it's alcohol or other substance use disorder, because that mystical experience is what gives people this moment of understanding that I don't want to continue my life like this. It's hurting me, it's hurting myself, I mean others around me. And that might be just enough to be able to then shift them into a different way of being. For some people, it's much more complicated because there's such layers of trauma. You peel back the substance use, that's your main coping strategy. Now you have all the symptoms and the trauma. So then you got to do the deeper work, right? This is where MDMA can be super helpful in that, is to go to the deeper layers of what is underneath this substance use that's driving this pain, right? And so when we go to the depths of it, then we can actually uncover it and help it bring to consciousness and heal it and release it. Because you'd be surprised how quick trauma work can be once we can get someone to be able to feel stable enough to actually go to the past and face what they need to face, feel what they need to feel, and release it. People are surprised. They've been carrying it for decades, and it takes a few sessions. It's amazing, but it's getting people to that place. So where do we create those safe places where people can feel connected, feel cared for, feel that they can trust? That's really like those key ingredients to making that trauma work happen, that release. So I hope to see more research that will show us the actual statistics around it. I know that there is already research out there that you might be able to look into around studies that were done on LSD as well as psilocybin around substance use. Yeah.
Stay tuned. BCCSU is launching a study on psilocybin to treat substance use disorders later this year, early next year. Nitasha is leading that study. And just for people in the recovery movement, it's interesting to note historically that Bill Wilson, one of the co-founders of AA, Alcoholics Anonymous, partook in LSD experiments or guided LSD sessions in the 1950s, and he was a strong advocate that it was a perfect complement to the AA model, the 12-step recovery model, with that sort of spiritual insight that he thought could be derived from a carefully guided psychedelic session. And unfortunately, at the time, he was kind of ostracized from the more mainstream AA movement because of his views on that. But I think now the latest science is corroborating his faith in that. So I think we have time for one more question, and then we have to wrap up. Oh, well, okay, we made two more questions. Sorry, I didn't. You were up earlier, so why don't you go, and then we'll have one more, and we'll wrap.
This is probably a quick question. Roger Walms and I work in Emerge and Addictions in the Mid-Island, Vancouver Island. This is exciting. The idea of a paradigm shift to deal with addictions is probably exactly what we need, because we're not making a whole lot of headway in other areas, perhaps. My question really is around whether we understand the biochemical model well enough for us to develop confidence in this. Because a lot of us who are a bit more traditional in our approaches, although we understand the beauty of holistic approach to medicine, I think we do need that biochemical model to support us in this. And I just wonder if that's well understood, if it's understood well enough for us to be able to move forward in the short term with this, or are we leading a lot of this to experience, just in terms of what you're describing?
The biochemical model meaning
I think we have a pretty good picture of, at least to some extent, of what happens in the brain when people take psychedelic substances. I think what we lack is a definitive biomedical picture of what happens in addictions. So, when we look at large samples, and we see positive results from clinical trials, and we see cross-sectional results from cohort studies, that tells us there's a signal there. Whether we're going to understand addictions from a biomedical perspective coherently enough to say, okay, there's the target, and now we're treating it with this chemical, and it's going away, I don't see that coming. So I don't know if we'll get that level, but at least for me as a clinical scientist, to see resolution of symptoms and to see carefully controlled cohort studies and clinical trials. That does it for me without necessarily reducing it to a biomedical mechanism or biochemical.
I would beg to differ on that one. I think we have a very good biomedical model, biochemical model of addictions. We know that addictions affect the brain circuits that involve the endorphin apparatus in the brain, which has to do with pleasure, reward, pain relief, and attachment to other people. We know that addictions affect the incentive motivation rewards of the brain, the limbic system, the nucleus accumbens, and its prefrontal lobe projections, the dopaminergic system. We know that addictions affect the stress regulation system, so that addicts don't have good stress regulation. They turn to the addiction to regulate their stresses. And we also know that addicted people, if you look at brain scans of them, you have abnormalities of the orbitofrontal cortex, which has many emotional functions, one of them being impulse regulation. So we have a pretty good brain anatomical, brain chemical picture of addiction. And that makes sense, given that all these circuits develop in interaction with the childhood environment, and under trauma, they won't develop properly. However, I don't think we need to get too hung up on brain chemistry. I mean, let's face it, we've been using antidepressants without a clue about how they work for decades. I mean, nobody's ever demonstrated a serotonergic abnormality, but we give Prozac, and it works in some people. It actually works. It's helped me. I mean, I know it works, but not that we have a good model of it. So I'm a Zac, you know. If they clinically work, forget the highfalutin science.
Okay, I'm being given this signal that we have to stop the panel now. They've got to turn the room around, and so I'm so sorry. We don't have time for more questions or comments from the panel, but thank you everybody for participating, and the panelists again for contributing.